This animated video is a demonstration of iGuide 2.0. This shows the use of iGuide in placing the neck-defining suture along with the trampoline platysmoplasty. The operative plan includes preoperative marking to note ptotic submandibular glands and platysmal bands, positioning of the head and neck, infiltration of the head and neck and face, tunneling of the neck and face, liposuction if indicated, facelift if indicated, and then lastly the neck-defining suture and trampoline platysmoplasty. As in all neck cosmetic procedures, it's important to have exposure and visualization. This animation demonstrates the various places of a pillow that will help extend the neck. The best place is underneath the shoulders, thus allowing the most extension of the neck. The neck area is then infiltrated, the area is tunneled with a liposuction cannula, and then fat is removed if it is indicated. And lastly, the placement of the matrix, either the NDS or the trampoline platysmoplasty. This procedure can be used as a standalone procedure in a younger patient with good skin elasticity or in conjunction with a facelift to treat the neck portion of the rejuvenation. The sequence involves injecting the neck with a tumescent fluid followed by tunneling the subdermal area. These markings indicate where the trampoline platysmoplasty will be placed and are not placed at this point in the operation and are for illustration only. Prior to doing the liposuction, the entire neck and facial areas are tunneled with a 3 mm spatulated cannula without any suction applied. This will elongate the ligamentous attachments as well as roughen the surfaces, therefore creating a scar interface which will aid in healing as well as the longevity of the results. This illustrates the markings of the submandibular glands as well as platysmal bands and the various pivot points for the neck-defining suture. There are 2 points over each area, 2 over the midline, 2 over each right and left mandibular gland, and 1 behind each ear, which will act as the anchor point. The sequencing of 1, 2, 3, 4, and 5 is the left limb of the suture that will be threaded underneath the skin in the subcutaneous space with use of the fiber optic lighted suture rod. The right side is marked with letters, and the threading will sequence from A, B, C, D, E, and out E, where the suture ends will be secured. After marking the various sites, the puncture device is then used to puncture each area. The elevation of the skin here illustrates that the skin is elevated secondary to the tumescent fluid as well as tunneling. It is per surgeon preference if the surgeon would like to pinch the skin and then use the puncturing device. All areas are punctured and the puncture device is rotated left and right 1/2 turn. This dilates the small puncture, allowing the suture rod to pass easily. The dermal attachments around each puncture site are cleared using a clearing device. The design of this tool was such that it needed to be rotated in a clockwise fashion in order to allow the sweeping away of the ligamentous attachments around each puncture. This will allow the easy passage of the suture rod in and out of each puncture as the suture matrix is weaved underneath the neckline. The neck-defining suture that is placed here works very effectively to elevate the structures and skin at the posterior aspect of the neck. This includes the submandibular glands and underlying soft tissue, as well as the cervical mental angle, as well as the areas around the angle of the mandible, which will help define the jawline. The suture rod is then activated by attaching the light source. The illuminated tip is then inserted in the midline puncture marked with 1, and it's carefully threaded to the patient's left. Visualization of a bright yellow spot of light is necessary to ensure the accurate depth of travel of the rod in the subcutaneous space. Each time the rod is brought out, the tip is left in the space and the rod is pivoted and rotated, and it travels on to the left side of the face to point number 3. The rod is then carried about and around the angle of the mandible up to point 3, where the rod is brought out until approximately 1 centimeter of the tip still remains in the subcutaneous plane. The external portion of the rod is then rotated downward, allowing the internal portion to rotate upward, oriented towards the mediocanthus of the left eye. The rod is then brought up so that it will encircle the ligamentous attachments in the mastoid area, and then directed downward to point 4, where it is brought out. The ligaments in the mastoid fascia are quite formidable and will anchor the suture and allow this to elevate the structures at the posterior aspect of the neck. After pivoting the rod through point 5, the rod is then brought out through point 5, and the suture is not cut as it is in this video, but is left intact, and the suture rod is placed in a protected place. This suture will be used to carry on the operation by placing the trampoline platysmoplasty anterior to the neck-defining suture. Remember, do not cut the suture. It'll just be tied here when both limbs are threaded in the subcutaneous space, and then the suture will be continually weaved anteriorly using the trampoline platysmoplasty procedure. The right limb of the neck-defining suture is then placed in the same fashion through each puncture site. Visualization of the bright yellow dot of light shows that the rod is in the correct plane. If the light becomes dull or red, the rod must be withdrawn and then redirected more superficially. If the rod passes too deeply underneath the platysma muscle, this may result in recurrent or residual platysmal banding and a less than ideal result. In the worst case scenario, the rod could create an injury to deeper structures in the neck. Rod is then brought out through point D. It will then be pivoted, leaving the tip of the rod in the subcutaneous space, and the rod will be brought out through point E5. Of note, the sutures are not cut at this point. Suture rods are left intact and the sutures are tied together. And then the matrix is carried on anteriorly to place the trampoline platysmoplasty. This animation illustrates the tying of the knot at the point just 1 centimeter anterior to the incision site of the first suture consisting of the neck-defining suture. It's important to throw the first throw either using a single throw or double throw surgeon's knot to set the tension at the neckline. With the neck-defining suture, adequate tension is extremely important in order to obtain success of the procedure. If the suture is too tight, the patient will have an overcorrected neck and will feel a sense of tightening as he or she flexes the neck. If it is under tension, then there will not be any evident results, and the patient will not be happy with the operation either. So the point at which you have the perfect amount of tension is when you have the neck extended and you throw the first throw of the suture and pull it and tighten it just to the point where you just see the first signs of visible tensioning of the skin. When you see this, you can go ahead and put the second throw in to lock your suture. It doesn't matter what type of knot you use to tie the matrix in place. Whatever works best for you will work for the neck-defining suture. So once again in review, you throw the first throw, which will set the tension. You observe the neck and look for the point where there's just visible tensioning of the skin with the patient's neck extended. Once you've established the correct amount of tension, then you can go ahead and lock the knot by placing another throw. The first throw can either be a surgeon's knot double throw or just a single throw in a square knot, as in this application that you are seeing right now. I always throw another throw so that I have 3 throws of the knot to further secure the knot in this region prior to completing the remainder of the procedure by proceeding anteriorly and placing the trampoline platysmoplasty. The trampoline platysmoplasty is then placed after the neck-defining suture. This illustrates the tape that is used and placed along the jawline. This is included in the iGuide surgical suture system. As you'll note, there are alternating lines and dots. These are stenciled out from a point extending anteriorly to a point posteriorly, just at the posterior aspect of the angle of the mandible. The reason there are alternating lines and dots is that during the weaving of the suture matrix, this allows the surgeon to go to every other dot just as you would if you were lacing a shoe one lace at a time. Usually in a woman with a normal sized mandible, 3 pivot points are used on each side. In a male with a larger jaw, 4 to 5 on each side. The marks underneath the jawline indicate pivot points where the rod is able to pivot as it travels underneath the jawline over the curved surface. These random dots allow the rod to pivot as it passes underneath the jawline. The puncture device is then used to make a puncture in each of the marked sites. It is rotated to the left and right 1/2 turn, thus dilating the puncture. These are the anchor puncture sites on the lateral ramus, where the suture will be weaved around the ligamentous attachments. The area underneath the jawline, these are called pivot points that allow the pivoting of the rod as it travels around the curved surface of the jawline underneath the mandible. The dermal attachments are then cleared using the clearing device, which is inserted in each puncture, and it is carefully rotated clockwise 2 to 3 turns, allowing the sweeping away of the dermal attachments. The sequence of each maneuver is just the same in the neck-defining suture in order to create the surgical field and prepare it for the light-guided suture rod. As the clearing device is inserted, is then rotated upwards so that it is perpendicular to the skin surface and is elevated. Some blanching can be seen where the tip of it is located as it is rotated clockwise 2 to 3 times. The matrix is then created by grasping one of the suture rods which exited through the puncture wound where the neck-defining suture was placed. The midline, most posterior neck-defining suture puncture site is used as the insertion site for the suture rod. Suture rod is then passed in the subcutaneous plane. If it passes too deeply, a dull red light will be seen transilluminating. This means the rod needs to be backed up and re-advanced more superficially. If the rod passes too deep, the muscle may be penetrated and the patient may have early, recurrent, or residual platysmal banding and less than ideal results. The rod is then almost brought out until there is approximately 1 centimeter of the rod in the subcutaneous space. The rod tip is then rotated, allowing the subcutaneous portion to be oriented towards the mediocanthus. It is then advanced approximately 2 centimeters, encircling and engaging these ligaments before traveling back underneath the jawline. The suture matrix is weaved in a crisscross fashion, going to every other mark as the suture is advanced anteriorly towards the submentum. Eventually the suture will be brought out through the submental stab incision where the liposuction access was obtained, as well as tunneling access. When the procedure is used in a patient after a neck lift or other facelift procedure or even liposuction of the neck, if there is no fat to be removed, only tunneling is performed prior to weaving in the suture matrix. Liposuction is only performed if fat is present. It's important to note that with each passage of the rod underneath the jawline, if there's any difficulty, it is okay to puncture and make a new pivot point underneath the jawline. The rod was designed to be straight and should not be bent during this procedure. Therefore, if multiple pivot points are needed to travel around the curved surface of the jawline, they are necessary and will allow the easy placement of the suture matrix. Once again, illustrating the rod as it is rotated, encircles the ligaments, and then engages and is advanced downward underneath the jawline. With each passage of the suture rod in the subcutaneous space, the suture is grasped by the surgeon and pulled, thus keeping tension on the suture throughout the entire operation. If the surgeon does not do this and reaches the end of the operation with a loop of suture out of the submetal incision, it is almost impossible to tighten it at this time, secondary to the braided nature of the suture and the weaving around several ligamentous attachments. Upon completion, the two ends of the suture are tightened, the suture rods are cut free. The assistant puts gentle upward pressure in the submandibular area, thus helping to place tension on the suture matrix. The appropriate amount of tension of the trampoline is obtained when there is visual dimpling of the two anterior anchor points along the lateral ramus, as well as visible tension lines underneath the jawline. This dimpling and the tension lines resolve in most patients within 24 to 48 hours. During the first month, when the patients open their mouth widely, they will note some dimpling, which resolves in 4 to 6 weeks. This illustrates what happens when the suture matrix is tightened, the skin approximates the muscles, thus closing the dead space. Patients are placed in chin straps as well as cotton compressive dressings overnight. They are instructed on the first day post-op to take a shower and apply ice as much as often. This summarizes the preoperative marking, positioning, infiltration of the neck, tunneling of the neck, and liposuction in this patient, as well as placement of the neck dividing suture and trampoline platysmoplasty.